The World Health Organization recommends 10 intensive care beds per 100,000 people. Jamaica's population stands at roughly 2.8 million. By that standard, the country should maintain about 280 ICU spaces. Instead, there are approximately 43 functional ICU beds across the public health network and 56 neonatal ICU for the country's most vulnerable newborns.
Currently in Jamaica, we are just about 1.5 beds per 100,000. So we really way behind in terms of the number of beds available per 100,000. Those might look like just statistical numbers, but those numbers actually have consequences. They come in play. So what am I saying? I'm saying that for every 100,000 people in Jamaica, we probably have just one ICU bed. So you have 100,000 people chasing one bed. All right. So it's not 100,000 sick people, but in that 100,000 population that you're talking about, you're probably saying, even if you're saying 1,000 of them, which is about 1% or so, even at 1% or even 0.5%, 500 of them would require ICU bed at any particular point in time. They're still chasing one bed. We're really in dire need of more ICU bed. Our capacity absolutely needs to grow. But ICU, like I said, is a very expensive project.
At Kingston Public Hospital, the largest public hospital in Jamaica and the Caribbean, there are only 7 ICU beds and sometimes only 5 are actually working. At Victoria Jubilee Hospital, just 2 ICU beds stand between critically ill mothers, newborns, and tragedy. Between 200 and 300 patients need ICU care at KPH yearly. That's roughly 30 patients monthly. But space decides who gets in and who must wait.
We have infrastructural challenges. We're actually displaced right now. We're not in our regular space because we're awaiting, repairs. You have equipment. That is the buzz thing. Everybody knows about that. Lack of ventilators, lack of properly functional monitors. But there's lots of equipment that an ICU is dependent on to function. It's not just a ventilator. That's a major piece of equipment. For us, our challenges are in maintaining that. Our equipment tends to be and nature of how expensive it is to procure, how expensive it is to maintain. For us, offering efficient management then with consistent supplies, consistently maintained supplies, consistent access to supplies, consistent access to diagnostics and diagnostic capabilities, those hamper our everyday ability to meet the needs and the demands. At least 80% of the patients that are referred to us on a daily or a yearly basis, we do not have the space for. They refer to us, but we cannot accept. Out of those referrals, though, maybe half of them are appropriate, meaning they are candidates for an intensive care space. We are unable to meet them because of the lack of resources or spaces.
Almost daily, doctors face the unthinkable reality. They cannot admit critically ill patients simply because there is nowhere to place them.
First of all, you have to have a reasonable prospect of survival. So that's the first and foremost. We have to accept as hard as it is. The public doesn't understand that, maybe even some of our own colleagues, but within intensive care, we accept that at some point you will pass. Your condition might be terminal or it might be past the point of reasonable survival. However, once we assess the patient clinically and we decide that there is a chance that this component could be reversible, and we have the means, sometimes even when we don't have the means to reverse it, but we can stabilize them and get them to a point or transfer them, whether within the country or outside of the country, to have an opportunity to have that condition reversed and targeted therapies, then we are on the side of taking that patient. But we do look at prognosis, meaning based on your medical condition, what is the likelihood of you surviving with or without our interventions, and then we decide based on that. So we triage a lot to decide who gets the space or not. I think even if we had an abundance of space, because the ICU puts such rigorous demands on a patient, meaning functional recovery afterward. You come into the ICU for one thing, but while there you develop several things that have to be managed and treated. And so to put a patient through that may not always be what is best for the patient. You still sometimes have to die with dignity. Families, it helps them. They think they did everything they could, but we have to decide if that serves the patient, because it is a lot to do to someone who has a 2% chance of survival, and when they recover, what are they going to be like, right? So it's very difficult. It comes with experience and time to make those decisions, but we always are on the side of life. That's the whole reason the ICU started in the first place, was to ensure that we could go beyond regular care and preserve life.
When those units fill, the overflow moves to high dependency units designed for lower acuity cases.
ICU, by definition, is a specialized department of a hospital where care is provided to the most critically ill patient. So it's a highly specialized unit that has specialized medical equipment, highly trained medical staff, and they provide care to the sickest of the sick amongst us. And there are different levels of ICU. So the World Federation of Critical Care and Intensive Care, all right, as well as the World Health Organization, will tell you that there are at least 3 levels of ICU. Those are referred to as level 1 ICU, which will just provide basic monitoring, and in some institutions they might refer to them as a high dependency unit in some instances. They provide just basic monitoring to these patients, and then there are level 2 ICU, where it's a step above level 1. They can support certain organ systems of the body. They can provide things like what we refer to as like inotropic support, vasopressor support, central venous monitoring, etc. And then there's level 3 ICU, which can give you multi-organ support. So you're really talking about patients who are extremely ill, or patients who require complex surgical procedures, cardiac surgery, complex neurosurgical procedure, complex vascular procedures. So these patients will require level 3 ICU. Beyond that, there are, of course, a very different classification process for the pediatric patients. And so ICU can also be general ICU, or they can be specialty ICUs. So you have things like the neonatal intensive care unit or the pediatric intensive care unit. In some jurisdictions, especially in North America, you might have things like the cardiac intensive care unit, neurointensive care unit, trauma ICU. So there are different categorization.
You would have, say, the PROMAC units were supposed to be maternal high dependency units. Many of them are non-functional. So yes, you may say that there's a HDU at Spanish Town Hospital maternity ward, the PROMAC unit. I don't think that's functional now. St. Anne's Bay, similar situation. So many of them have been repurposed to being overflow. Then you have the creation of these makeshift high dependency units in the recovery areas where patients going in and out of surgery would normally rest. And in a situation like that, what happens is that sometimes when you have patients tied up, even inside the operating theater, the anesthetic machine, when you finish surgery, you can't extubate the patient, take out the tube. They have to just stay there on the theater bed until you can fly them out to an ICU space. So you back up all of the operating theater list, and this is especially in the rural hospitals. So HDUs pop up as the needs arrive. You can't say, hey, we don't have the HDU capacity. If you have a theater ventilator, that operating theater becomes the high dependency unit.
That gap is not a statistic. It is a lived crisis.
Patients come from St. Mary because the board of St. Mary and St. Catherine, Clarendon, Kingston and St. Andrew. Patients will come to the Spanish Town Hospital. We know that because of the addresses that we get.
We're a blended ICU. We are medical patients, surgical patients. Our department actually cares for obstetric patients and gynecology patients as well. We're a hospital complex. It's a KPH and the Victoria Jubilee Hospital. So because we're a tertiary institution, we do care for any kind of case, essentially. Anybody who is critically ill, so any patient who has an organ that needs to be supported, we'll care for them. We're primarily surgical, so maybe 70% of our admissions are surgical. Victoria Jubilee has their own ICU HDU area now, so they care for their patients. Sometimes we see those patients in our ICU, but most of the times when you're critically ill, you manifest in your lungs not working or your heart not working, your kidneys not working. So we will support patients, help them to breathe if they have what we call respiratory failure. If they have major overwhelming infections, so infections of the whole body, inflammation in the whole body, we'll attend to those patients. We see a lot of trauma in our unit. About 30% of our admissions are related to trauma, both accidental and non-accidental trauma. So, head injuries, motor vehicle accidents, compound injuries, we'll see that and attend to that. But we manage people with severe asthma, diabetes that has put you at the brink of death, that kind of a thing. Very severe viral infections, pneumonias. We help people through that.
We'll be right back. "23 high-dependency areas have been carved out to catch the overflow across the public health system, and 19 recovery room spaces to ventilate patients for a short, fragile window of time before they must be moved. Stretching them beyond their purpose introduces clinical risk."
The outcomes are going to be worse. If you're fortunate, the patient is fortunate, they may pull through because, again, you don't have the resources, you don't have the monitoring. If you have somebody in an HDU who really and truly should be in an ICU, their risk of infection goes up. The risk of having undiagnosed complications, those go up as well because in an ICU. And then, of course, the level of care that you have, because in many rural hospitals that are functioning with makeshift HDUs, they don't have the full complement.
Equipment is limited. Staffing ratios differ. Some major facilities operate without a single dedicated ICU ward. Spanish Town Hospital serves one of the island's largest urban populations, yet relies heavily on high-dependency care.
Based on the ratio as it relates to crit care patients to, it's really 1-to-1. At the most they will go is 1-to-2. So if it is you are managing 3 patients in the space, you really should have 3 crit care nurses to manage, but at least 2 in the space to manage 3 patients. Likewise, the neonates, you have, the babies really should be 1-to-1.